Our speaker, Dr. Philip Barber, is part of the PREVENT study, and if you read your digital examiner, you'd find out that he's at the University of Calgary, where he's associate professor of neurology and radiology, and he's also director of the Calgary Stroke Prevention Clinic and a member of the Calgary Stroke Program. This is my first time meeting Philip. I've met, I've emailed with George several times, but as I indicated in my notice, I've been part of this study now for 5 years and have finished, and this is why we're here tonight, because I heartily recommend it, because it's certainly something that's topical with all of us gray hairs and advancing in age, and the risk of transischemic attacks and their relationship to dementia. So why don't I stop there, Philip?
Well, thank you for that kind introduction, and also for inviting me to talk to you about the PREVENT VCI study. I never thought prior to today that in my wildest dreams, I would get a mention in the digital examiner, never mind to be on the front page. Anyway, I'd like to tell you about a rather mundane thing that happened today to me, and you may have experienced this yourselves. That I was online and an advert popped up, and the advert was about planning for retirement. Please bear with me that you are in the right talk. We're not going to talk about planning for retirement, but firstly, it made me wonder, maybe I'm a bit too young to think about retirement. And then secondly, I thought, well, maybe somebody's trying to tell me something that perhaps I should retire. And then I got thinking, and maybe I should think about the future and start planning for the future, as I'm not getting any younger. I'm in fact getting older, of course. So I wondered whether you might feel the same as me, that as you age, the most important thing is to cherish your physical and mental health and quality of time spent with family and friends. That's why I want to talk to you about the existential threat that may confront you and me as you get older, and that is of developing dementia. And today, the diseases that cause dementia are diagnosed when symptoms like memory loss start. And currently, there is no cure for dementia. And to have the best chance for halting these diseases, we need to intervene much earlier. And therefore, there is the potential to detect these diseases at the very earliest stages. So first, we're going to start with an exercise. I'm going to ask you to close your eyes. So close your eyes, please. You don't need to meditate. And I want you to picture somebody that has dementia. Maybe you know a family member who has dementia, or maybe you have seen a documentary recently about dementia. Now I want you to open your eyes, and the image you had in your head may have looked something like this person seen on the screen in front of you. Or maybe maybe some of you might have had an image of someone much younger, such as this person. And this person is Wendy Mitchell, who was diagnosed with dementia at the age of 58. She's gained notoriety with her media presence and her writings about dementia. What is remarkable about Mitchell is that she has severe impairment of episodic memory, which means she isn't able to remember events on a day-to-day basis. By using a combination of WhatsApp, making notes in the moment, and with the help of her daughter who filled in the gaps in her memory, she's been able to write a blog and write best-selling books. Her recent book, What I Wish People Knew About Dementia, is chock full of optimistic reversals, in which something that most of us would experience as upsetting or frustrating is turned towards the light. A problem has a solution. A loss can bring unexpected gains. The diagnosis of dementia does not need to be a death sentence, but can instead herald the start of a whole new adventure in being human. Mitchell's story is an inspiration because she teaches us that life is easier if we can turn despair into hope. And there is hope. And for this, we need to refer to what we know about the progression of the disease. What we know is that the diseases progress over 10 to 20 years. And there lies the opportunity, because if we can identify the diseases at the very earliest stages, so that preventative treatments and novel therapeutics have the best chance to work. It is currently not possible to cure or halt the progression of the diseases that cause dementia, because at the point at which the functional impairments are sufficiently severe for dementia diagnosis to be made, neurodegeneration has already progressed too far to be reversible. By this time, the disease is complex. Here I have simplified it into two distinct pathologies, Alzheimer's disease and vascular disease, but the overlap increases with advancing age, and this is termed mixed dementia. But there are other diseases that can coexist, making the disease extraordinarily complex in later life. But dementia is preventable. And here I present the 9 modifiable risk factors that, if identified early, appropriately managed, can potentially prevent dementia. Education is very important. There's a big factor early on in life. Sedentary lifestyle can also be a risk factor. Obesity, smoking, hearing loss, hypertension, diabetes, depression, and social isolation. So for treatments to work, we need to identify the disease as early as possible and before symptoms develop. So identifying which markers of disease can predict early dementia is a bit like an obstacle course or a long distance run. Just like we don't know which, when, or what order these marathon runners will reach the finish line, similarly, we don't know which of the early biological markers has the greatest sensitivity and accuracy for predicting who might be at the greatest risk of dementia. And such markers need to be accessible so they are as available to as many people as possible. This brings me on to the PREVENT VCI study. In PREVENT VCI, we are addressing the feasibility of detecting dementia-causing pathology before symptoms develop. We have recruited patients with minor stroke or TIA and controls, and we are performing a serial advanced MRI, assessing brain function and collecting fluids for Alzheimer's disease biomarkers. And we're repeating the imaging at 1, 3, and 5 years and following up with cognitive tests. And the primary outcomes is cognitive decline and brain atrophy rates. So one of the major primary outcomes is volumetric change. What we are actually studying is brain atrophy. Now, it may seem shocking to you that as we get older, our brain actually reduces in volume. But for most of us, this is an entirely normal aging process. But when the diseases that cause dementia become established, the brain shrinks or atrophies much faster, and specific regions such as the memory centers of the hippocampus and medial temporal lobe seem to undergo accelerated atrophy compared to the rest of the brain. And we can measure the volumetric change and quantify the progression of disease. We're also studying the way blood flow changes in the brain. In Alzheimer's dementia, we see patterns of reduced blood flow in particular regions of the brain, but this often correlates with areas of advanced brain atrophy. In our patients, we are detecting similar patterns of regional low blood flow, which are independent of change in brain volume. Therefore, these patterns of reduced blood flow in the brain might be useful markers of early disease progression. So we can detect early disease at a group level. The more challenging next step is estimating the risk of dementia in an individual person. And to answer this question, we have built a platform of well-characterized subjects and biomarker data that can best inform us with the help of advances in computing power and high-fidelity machine learning algorithms about an individual's risk of dementia. Our vision is to build on these solid foundations by including novel technologies such as genetic long-read genomics, unsupervised cognitive tests, and biophysical data from wearable technology that we all seem to be wearing now. And we can harness the inspiration from people with dementia, those closest to us, family or friends, or maybe the likes of Wendy Mitchell. I'm going to leave you with the words from another inspiration, Terry Pratchett, who at the time was suffering from a rare form of early Alzheimer's disease. This is Pratchett getting to the root of the problem with the importance of early detection of the disease. It is this that will give us the best opportunity to treat the disease before the disease causes impaired brain function. Thank you very much. Now I'd like to invite some questions and to which I can provide the answers, hopefully.
I've heard online that certain type of drugs help people with medium to advanced dementia. And one of them was kind of a surprise to me. They had mentioned that Viagra and other stimulant drugs actually did help. Is that in fact true?
Thank you for your question. That's an interesting question indeed, Warren. So there are treatments, but currently we do not have any disease-modifying treatments. So there are treatments to provide symptomatic relief, like providing Tylenol for pain. So there are some medications that are clinically proven, like donepezil, commonly referred to as Aricept, that can be bought. It's prescribed actually, that can provide some mild assistance to patients with Alzheimer's disease in terms of their symptoms and function. Viagra, I'm not familiar with the relationship with Viagra and improved brain function, but I'm sure Viagra can do anything in terms of improving blood flow to the brain. But whether it can actually help brain function, as I'm not quite aware of that one.
The premise that was on the internet was that it expands your blood vessels and gets more blood flow to the brain. I have no idea whether that's a logical conclusion or not.
So it certainly is a vasodilator, as we know, but I don't know whether it causes sufficient changes in blood flow in the brain of patients with Alzheimer's disease that will actually result in improved brain function. The problem with Alzheimer's disease is that by the time we actually start treating it, there's already been quite considerable amounts of injury, neuronal loss, and change in brain function. And that's pretty much the point of the research that we're doing, is to try and identify some early markers of disease 10, 20 years before the disease actually manifests.
In the chat, Philip, Bob Phillips is asking, is it hereditary?
So again, very good question. So we know in certain types of Alzheimer's disease, primarily in patients with younger onset with strong family history, there's a strong genetic basis for it. So about 1 or 2% of Alzheimer's disease is familial. But the vast majority of Alzheimer's disease occurs later on in life. And it's much harder to decipher the genetics, which becomes very complex, and the environment. So in the older version of Alzheimer's disease is is very complex. The pathology is complex. There's not a single gene or abnormality that will actually cause Alzheimer's disease. So we haven't actually identified a single or multiple genes that seem to be associated with Alzheimer's disease later on in life.
Philip, very interesting what you shared with us. I'm wondering, a number of people have said, or there's been reports that if you play word games, Scrabble or Wordle, or do crosswords and those sort of things, that throughout your life, that you reduce the risk of Alzheimer's or dementia. Is there any studies on that or any truth in that?
So just to repeat your question, so your question relates to performing puzzles, crosswords, etc., to stimulate your brain, and will that reduce your risk of developing dementia? Yes. That's an excellent question, and I think there is evidence that utilizing your brain, whether it's by doing daily quizzes or crosswords or Sudoku or reading, as well as physical activity, social interaction, maintain your emotional interaction with people, certainly helps your brain function, and may protect your brain in the long term. So we certainly advocate, post-retirement or even before then, to make sure you're active physically, mentally, socially, and emotionally.
It's interesting. My mother, she lived to 90, and she lived in England and Wales, but she did the Daily Telegraph crossword every day of her life. It was part of her routine. Mm-hmm. And right up to when she died, she could do the crossword. There seemed to be nothing wrong with her brain at all, or brain function. Yeah. I think what happened is her body and body parts sort of let her down over the years. Does that sound familiar? And have you done any research on this kind of thing? Is there something we can refer to?
It sounds like your mother, she was active through her life, and she stood out as she got older, and that she maintained a lot of her mental abilities.
Yes.
Whether that was because she read the Daily Telegraph every day, I'm not entirely sure. But we'll put it down to that.
Yeah, she did the crossword every day, which is not an easy one.
Oh, no, it isn't. That's true.
Familiar with it. And she, to very late in life, she played bridge, which is mentally tasking for most of us. So, yes, her brain function was very good for 90 years. And so she enjoyed her life really very much and didn't have to worry about forgetting things.
So I mean, one way of addressing your question is to reflect on the fact that she reached a very old age and maintained her cognitive function to the very end, and in fact that she might be a bit of an oddity in that respect. And so we can maybe learn something from people like your mum. What is it about people like her, and what can we learn about very old people that maintain their cognitive function? And there are several lines of research that are looking into that. That's not been specifically addressed by the Prevent VCI study, but there's several offshoots from the study and potential collaborations to look at that. I mean, I had a conversation with a genomics company this morning, and that's one of the lines they're taking, is that they're looking at very old people with normal cognitive function for their age, and looking at their their genetic makeup, if you like, and comparing it to similar cohorts with dementia and to see whether there's any signal in their genetic makeup that can identify particular genetic susceptibility or proteomic influence.
I wanted to get a comment from Philip regarding some of the things I've heard from research doctors, as well as what I've seen on the internet. And they were saying that many of these unusual diseases of the brain, including multiple sclerosis or other things that don't seem to have an apparent cause, actually had a bacterial intervention, typically from your gut bacteria, started several years ago. And I don't know much about that at all. But I was wanting to comment on that. And also, one other comment on the internet said that if you end up with plaque on your teeth, like, the white stuff around the base of your teeth, that the doctors and the dentists can just about guarantee you'll have cardio disease as well as brain disease in future life. Could you comment on that, please?
Thanks, Warren, for those interesting questions. So your first question was related to, I think there might have been 3 questions actually, because you said they refer to infections and brain disease. Is that was one of the lines of your questioning?
Well, I don't know that it would be direct infection. What they were saying is that it was a gut imbalance of bacteria that may be caused, I guess sometimes I've seen alcoholics do it, where they end up filling their gut full of alcohol that kills all the good the bugs, and then the bad ones kind of take over slowly. And that was one thing that they said was one of the root causes for multiple sclerosis, as well as Alzheimer's. And I guess it could be attributing to dementia, but I don't know for sure. And then they equated the bacteria plaque that's on your teeth that gets into your stomach, into your system, and into your bloodstream, and eventually piles up in your tiny little blood vessels in your brain.
So really interesting question, and thank you for that. So there are several lines of investigation looking at what our researchers are referred to as the microbiome. And I don't know whether that is a familiar terminology to you, Warren, or anybody else in the group. But essentially it refers to this imbalance that you've read about in the gut of bacteria. And it's an evolving line of investigation. There's been investigations related to the so-called microbiome and the onset of Parkinson's disease. I'm not familiar with the research being done in multiple sclerosis, but again, I wouldn't be surprised if there were not investigations looking at this and multiple sclerosis. So yes, I can't provide you with specific answers other than saying that there is an evolving literature and research interest in the kind of the bacteria milieu in the gut and the development of these insidious diseases that occur in the brain. With respect to dental disease, we know that dental disease is a risk factor for stroke and vascular disease. And we always have to remember that it's not just the neurodegenerative disease like Alzheimer's disease, but there's a strong vascular component to the disease. So, yes, ensuring that you have good dental health and you brush your teeth and what have you, and visit your dentist on a regular basis. Now, your dentist might want you to visit on a more regular basis than is necessary, but that's not for me to comment. But certainly, there's a relationship with dental caries and gum disease and cardiovascular risk and stroke risk, and possibly with dementia.
Just in passing, the studies that I was mentioning took place in Germany and were probably about 3 years ago.
Okay.
Sorry, I'll just add to that if I could, Philip and Warren. I've just finished reading The Better Brain by Bonnie Kaplan. She's Calgarian, I think, and Julia Ruckledge. And they go into a lot about the brain and nutrition. So that's something you might want to consider. And they also even talk about plaque under the gum and above the gum, and the bacterial biome, etc. So it'd be a good resource if you're interested in following up on that. The Better Brain.
Absolutely, David. Thank you for that, and make sure I add it to my reading list.
Mhm.
In the interest of time, Dr. Barber, we don't want to take you past your deadline. Do you have time for one more question or two?
Absolutely. I'm really taken aback by the interest.
So one question I would have is, I know that you're at U of C, so you're here in Calgary, but are you taking applicants from anywhere else? We have some members that are in like Claresholm, Warrens, and Edmonton. You know, do you have people who are affiliated with you at U of A Hospital or the Royal Alex?
So good questions, Dorothy. The issue with, there is an issue with proximity because we're based in Calgary in the foothills. And this is a longitudinal study. So we're doing serial MRIs and cognitive tests and blood tests and potentially cerebrospinal fluid. The further people live away from Calgary, they're less motivated to come back. Now,
Okay.
we would consider somebody who was extremely motivated from anywhere outside Calgary, but they have to be extremely motivated to come back.
Okay.
So I'm just going to show you this slide with the inclusion criteria. So we've got maximum age of 80, men or women. We do ask you have to be fluent in English because all the cognitive tests are performed in English. The exclusions are contraindications to MRI, previous stroke or TIA. Hard of hearing would be if you're really deaf, it might be a problem to do the tests. We are excluding anybody with serious medical conditions. So what that means, if they've got severe cardiac disease or chest disease or any medical condition that will limit their life expectancy. And that would include also cancer, this particularly disseminated cancer. Are there any questions about the inclusion criteria?
Philip, you said, I think in the note I copied and put in the digital examiner from age 60. Is that correct?
Actually, our lowest age is 45.
Oh, wow. Okay.
The reason for that is that we know from the literature is that some of these diseases start as early as midlife.
Mm-hmm.
So we do see patients with TIA and stroke as young as that, and if not younger. So we have included those younger people, but we're going out to 80 as well. We're still actively recruiting, and will do so for the foreseeable future.
So you're saying somebody age 80 then could join the program?
They could join the program, yes.
Okay. And how do we do that? How do we join the program?
So I've got some contacts here. All right. So I got an office number. We actually we are getting a generic email, but George has kindly put his email down. And we do have a, what's this one, George, here? What's this? Is it the website or?
This is a link.
That's the link. That's the UFC link. So you can tap onto this link, and there's actually a forum there. You can basically ask a question of the PI, and if you're interested, you can say whether you're interested or not. So we do get volunteers approaching us from the community.
Good. Thank you.
However, there was a question in the chat asking why the upper limit of 80 is used.
So the upper limit 80. So we know this is these conditions occur as people get older, and there may be something that we can prevent as people get older. Now, the reason for 80 is once you get to 80, unfortunately, your life expectancy does decline and with every advancing year. And because it's a longitudinal study, we do want to restrict our attrition. That means people dropping out because of people become infirm, or they die, unfortunately, those kind of things. So ultimately, the study does depend on follow-up. So we're not taking very old people for that reason, because it does affect our follow-up.
Hello, Dr. Barber. Yes, it's probably faster if I do this by voice and try to type it out. So, what effects has dementia have on strokes and vice versa as the older we get?
Well, that's an excellent question. So from what I understand from your question is, what are the effects of stroke and dementia on your brain function and your mobility? So stroke classically can cause focal deficits. So it can cause weakness or impairment of language or vision. It generally occurs very suddenly. Whereas dementia, and I'm talking about the dementia that we see commonly, and that's the Alzheimer's mixed with the vascular disease, it's more insidious. So people might complain of Alzheimer's disease, for instance, of memory problems. So forgetting where the keys are, mislaying items, becoming disorganized, forgetting appointments, can't remember what they did yesterday, those kind of things. They're the classical memory type problems. But it's more complex than that. That's the kind of the canonical orthodox presentation. But we see in older people more mixed pictures. So they might become slower or have problems doing things like figuring out how to put the washing machine on, or the dryer, or the stove, or and combined with memory problems, they may forget that they've left the stove on. And with the vascular disease, they may have mobility issues, so they might become unsteady and have falls. So it's generally a quite insidious, slowly progressive problem. And that's the problem, is in that once we see people, the disease can be well established. So hopefully that's answered your question, Bob.
If none, and then anything final that you want to say, Philip?
Well, thank you for, I'd like to acknowledge and inviting me to your monthly meeting, and there'll be some great questions, and hopefully I've sparked some interest in the group. And if you'd like to sign up to the study, that you're more than welcome. You can contact George. That's probably the simplest way, and we can get you, if you're interested, we can send you a consent form. That doesn't mean you're obliged to be part of the study. Just means it's a piece of information, further information for you. And if you're sufficiently interested, you can get back to George, or if you have a fax machine or some way of scanning the consent back. George, would we give a digital copy and they can actually just provide a digital signature or something like that? Is that possible?
Yes, yeah, we are very
Um,
flexible, so we can just yeah, we can, if someone, you know, we can provide the copy and they can just sign and then email it back to us, and that's sufficient.
Yeah. So it's a pretty easy study in terms of time commitment. When you're here, you're probably here for 2 or 3 hours because you have to have an MRI, cognitive tests. We send you off to the lab to have some blood tests. But we're only asking you to come back very intermittently. So after the first visit, the next visit will be a year, and then possibly 3 years, and then 5 years. In some people, we on all people actually, we're asking whether they'd like to donate some of their cerebral spinal fluid. That involves a lumbar puncture. We understand that's an invasive procedure, but it's commonly done in neurology, and it's done under local anesthetic. And from what I understand from people that I've done the test on, it's better than going to the dentist. So that's something you might want to consider. There are some exclusions, so we'd have to screen you for that. But it's one way of getting, it's like a silver standard. It's not the gold standard. The gold standard would be pathology. It's the closest way we can get to your brain and to look at these proteins. So it's very valuable, and it's a pretty straightforward thing to do. And then we just basically keep following you up, and you know, we are a good contact for you if you have any problems. We do, this is research, so we do operate non-disclosure because we don't know what the results mean. And we want to protect you. We don't want information to get into the hands of the wrong people, like insurance companies. We're now utilizing machine learning algorithms which can basically gather a lot of this data and to find interesting patterns of associations. So the study is evolving, and as I mentioned, we've entered into collaborations with a genomics company. We've got great collaborations with our collaborator in Sweden to do the Alzheimer's disease biomarkers. And we're getting interest from bioengineers who want us to for our participants to wear things that we can get data from, like the heart rate, sleep data. I have a collaboration with an engineer who's designed a wearable technology to assess driving. So all these kind of interesting offshoots for the study.
Well, listen, Philip and George, thank you very much, and I hope you get lots of interest from our group. And as I say, when I joined, over 5 years ago now, I thought, well, anytime you get a free MRI of your brain, that can't be all that bad, to at least find out what's happening with regards to blood vessels.
Exactly. Well, I hope we've sparked your interest, and we look forward to any interest. Please send us an email if it's just simply a question, or if you want to commit to the study. That would be well appreciated.
Great. Well, thank you very much. And likewise, George, thank you.
Thank you so much for having us.
Thank you very much. Bye-bye.
Bye-bye now.
Bye-bye.